Updated clinical recommendations for the management of tuberous sclerosis complex associated epilepsy by Specchio, 2023. Prepared by Dr. Alsayouf, 09-2024. Children with tuberous sclerosis complex, TSC, may experience a variety of seizure types in the first year of life, most often focal seizure and epileptic spasms. Drug resistance is seen early in many patients, and the management of TSC-associated epilepsy remain a major challenge for clinicians. In 2018, clinical recommendations for the management of TSC-associated epilepsy were published by a panel of European experts. In the last 5 years, considerable progress has been made in understanding the neurobiology of epileptogenesis, and 3 interventional randomized controlled trials have changed the therapeutic approach for the management of TSC-associated epilepsy. Pre-symptomatic treatment with vigabatrin may delay seizure onset, may reduce seizure severity, and reduce the risk of epileptic encephalopathy. The efficacy of mTOR inhibition with adjunctive everolimus was documented in patients with TSC-associated refractory seizures, and cannabidiol could be another therapeutic option. Epilepsy surgery has significantly improved seizure outcome in selected patients and should be considered early in all patients with drug-resistant epilepsy. There is a need to identify patients who may have a higher risk of developing epilepsy and autism spectrum disorder, ASD. In the recent years, significant progress has been made owing to the early identification of risk factors for the development of drug-resistant epilepsy. Better understanding of the mechanism underlying epileptogenesis may improve the management for TSC-related epilepsy. Developmental neurobiology and neuropathology give opportunities for the implementation of concepts related to clinical findings, and an early genetic diagnosis and use of EEG and MRI biomarkers may improve the development of pre-symptomatic and disease-modifying strategies. 1. Introduction. TSC is a multi-system genetic disorder characterized by age-related development of benign tumors across several organs including the brain, skin, kidneys, heart, and eyes. TSC is caused by inactivating mutations in either TSC1 or TSC2 genes, RNA1-3. The gene mutation results in an overactivation of the PI3K ACT mechanistic, formerly mammalian, target of the rapamycin, mTOR, signaling pathway, which plays a crucial role from brain development processes to aging. Overall, more than 2,000 pathogenic TSC1-2 new variants have been described in the Leiden Open Variation Database, www.lob.nl-TSC1 and www.lob.nl-TSC2, making the genotype-phenotype correlation challenging. Identification of a pathogenic variant or deletion in TSC1 number 2 is sufficient for the diagnosis of TSC, regardless of clinical findings. Northrop 2021, Fru. However, about 5 to 8% of TSC individuals meeting definite clinical diagnostic criteria have no pathogenic TSC gene variant or deletion identified by direct sequencing of both genes or by whole exome sequencing analysis. 5 to 8. Epilepsy is the most common, 80–90% of patients, conquered of a large spectrum of neurological and psychiatric manifestation in patients with TSC. In addition, neurodevelopmental disorders with intellectual disability and autism spectrum disorder, ASD, and behavioral abnormalities are highly prevalent. 10. 11. Patients with TSC may experience a variety of types of seizures, epileptic spasms, focal, tonic, atonic, and tonic-clonic seizures in the context of an evolution toward Lennox-Gastaut syndrome. The majority of patients experience seizures in the first year of life, during 2013. About 5% of children develop epilepsy as newborns, often due to malformations of cortical development, meeting the criteria of focal cortical dysplasia, FCD, Mayer teen. The recognition of subtle focal seizures in infants by caregivers may be difficult. 15. In 2017, a panel of European specialists met in Rome to define clinical recommendations for the management of epilepsy associated with TSC, seizure. In the last 5 years, considerable progress has been made in understanding various aspects of this disorder, including the neurobiology of mTOR-dependent epileptogenesis. First of all, the International Tuberous Sclerosis Registry to increase disease awareness in Tosca, 17 has provided baseline data on more than 2,000 patients and new insights into the clinical characteristics and the natural history of TSC. Moreover, 3 international randomized controlled trials, RCTs, have changed clinical practices in the treatment of epilepsy associated with TSC. The EpiStop NCT02098759 trial showed that pre-symptomatic treatment with vigabatrin may modify the natural history of seizures with a delay in seizure onset and a reduction in seizure severity and the risk of epileptic encephalopathy, EE. 18. The EXIST-3 trial demonstrated the efficacy of mTOR inhibition with adjunctive everolimus in reducing seizure frequency in patients with TSC-associated refractory seizures. 19. Finally, the GWU Peace Care 6 trial documented efficacy and safety of cannabidiol, CBD, in reducing TSC-associated seizures compared with placebo. CBD is now approved by Food and Drug Administration, FDA, and European Medicine Agency, EMA, for the treatment of seizures in patients with TSC. Experts are now moving away from the traditional therapeutic approach with anti-seizure medication, ASM, applied after seizure onset, to a more proactive approach focused on pre-symptomatic treatment with vigabatrin or molecular targeted treatment with mTOR inhibition, QUISM. Advances in surgery improves access to this treatment for patients with multiple tubers, Hanan. To review new insights from the last years, a new panel of experts met in Rome in November 2022 to address specific questions. Each panel expert was assigned a topic to review beforehand and present at the meeting. The panel addressed the mechanisms of epileptogenesis, the predictive value of clinical EEG, brain MRI, and genetic biomarkers, and evaluated the potential benefits of pre-symptomatic treatment with vigabatrin in targeted treatment with everolimus, and other new treatment possibilities, including CBD and indications for pre-surgical evaluation. This paper outlines the issues discussed at the consensus meeting workshop and sets out updated clinical recommendations for current treatment of TSC-associated epilepsy, considering new concepts and changes since the last publication of the 2018 clinical recommendations. 2. Progress in understanding mTOR, dependent epileptogenesis, and co-occurring neurodevelopmental disorders. TSC is genetically complex because it involves both germline genes and somatic second-hit events. Second-hit loss of either TSC1 or TSC2, inducing mTOR hyperactivation, has been identified in TSC neoplastic lesions, but is less frequently detected in cortical tubers, suggesting a role for additional molecular mechanisms, 23-24. Extensive research over the past decade has provided strong evidence of the critical role of the mTOR pathway during brain development, controlling many basic cellular functions, such as energy metabolism, protein synthesis, and autophagy, to regulate cell growth, proliferation, migration, dendritic formation, and axon elongation. 25-26. The mTOR signaling pathway has a crucial function in the process of neuronal and astrocytes differentiation, as well as in oligodendrocyte lineage development. Balanced spatiotemporal mTOR signaling is crucial for the proper development of the human cortex, 25-27-28. Accordingly, dysregulation of the mTOR signaling represents a common pathogenic mechanism of a spectrum of malformations of cortical development, sharing histopathological and clinical features, including epilepsy and co-occurring neurodevelopmental disorders. 225-29. Timing of mTOR activation plays a crucial role and subsequently determines the neuropathological and clinical phenotype. 29-31. Interestingly, in experimental models, the level of mTOR hyperactivity correlates with the severity of epilepsy and associated neuropathology. Cortical tubers, subependymal nodules, and subependymal giant cell astrocytoma are the main pathologies in the brain of TSC patients. Cortical tubers represent the neuropathological basis of epilepsy and consist of areas of cortical dyslamination containing different cell types, including dysmorphic neurons, giant cells, and reactive astrocytes. Cortical tuber formation is a complex and dynamic process starting in fetal brain but continuing as the brain matures. 10 Visual detection of cortical tubers on neuroimaging is limited in prenatal and early postnatal period, and it improves with the myelination process during the first 3 years of life. Prenatal brain MRI revealed cortical tubers in 20 out of 30, 66.7% patients in the study of Slowinska et al. 35. Predefined advanced imaging protocols with 3D T1 and T2 sequences are required to improve lesion detection in the newborn with TSC. Some MRI sequences as arterial spin labeling, ASL, have been reported of help in early childhood to identify tubers in relation to EEG slow waves. 6. But this application needs further validation. Insights from a variety of in vivo and in vitro genetic models and from human pathology have shown that epileptogenesis in TSC is a chronic and dynamic process leading to early onset and difficult-to-treat seizures. Co-occurring neurodevelopmental disorders and mTOR-related neurodegeneration, i.e., increases risk for tauopathy. 10 This process may start prenatally and can continue long after the epilepsy diagnosis. Knowledge about the complex biological mechanisms contributing to network dysfunction during brain development, even beyond the early period of epileptogenesis in individuals with TSC, is rapidly increasing. 10 Experimental and human studies provide evidence of early and sustained oxidative stress and inflammation, accompanied by blood-brain barrier, BBB dysfunction, and extracellular matrix remodeling. 40. Dysregulation of mTOR signaling itself may result in developmental alterations of the balance between excitation and inhibition. Converging evidence suggests that the pathological network underlying early appearance of seizures is characterized by persistence of immature patterns of neurotransmitter receptor expression and function, i.e., GABA receptor, and/or disrupted GABAergic interneuron network development and organization. 10-38-42. Moreover, the direct influence of mTOR pathway, dysregulation on oligodendrocyte differentiation, and myelin formation could further contribute to abnormal cell signaling and network dysfunction. 10-38-43. Other pathways that might be related to the mTOR pathway have also been suggested as interesting targets in therapy of TSC-related seizures during brain development, such as the inflammatory pathway, IL-1, CXCL10, 44, and the GLUN2C subunit of the NDMA receptor, 45-46. Combination of multiple targeted interventions might be needed to further increase the efficacy of mTOR inhibitor treatment in TSC-related seizures in humans. There is a complex relationship between epilepsy and autism, and TSC is among the major causes of syndromic ASD, 1147. TSC2 mutations, tuber volumes and location, infantile spasms, and early onset seizures have been reported as the most important risk factors for ASD, 48. A developmental disruption of GABAergic cortical interneurons linked to abnormal generation, migration routes as well as their molecular and functional diversifications can explain the concomitant occurrence of epilepsy and autism. 10-38-42. Although there is a strong association between the presence of epilepsy and TSC-associated ASD, ASD should not be considered solely as a comorbidity of early onset epilepsy and the infantile epileptic spasm syndrome, IESS. Ever since the last century, clinicians have always observed that seizures appear in the first months of life, while ASD risk is recognized much later and is typically not diagnosed before 2 to 3 years of age. Therefore, their understanding was that early epilepsy onset may lead to autism, even if there is morphological substrate of autism, brain lesions, and some autism features are seen in patients without epilepsy. 11-11. Recent evidence showed that early risk of autism can be detected already in the first year of life. 49-50 hounds. Complex cellular and molecular events play a significant role in determining a high risk for both epilepsy and neurodevelopmental deficits in infants and children with TSC. 51-53. TSC can be considered a model of genetic determined developmental and epileptic encephalopathy, a group of severe epilepsies that are characterized by often drug-resistant seizures and encephalopathy related to the dual impact of the seizures and of the etiology 54-59-5. 3 predictors of drug resistance. TSC-associated epilepsy management is still a challenge because of high percentage of patients developing drug-resistant epilepsy, DRE. Data from the Tosca registry revealed that patients presenting with focal seizures, whether or not combined with IES, were more refractory than patients presenting with epileptic spasms only, but the prediction of DRE is still challenging. 17. In a prospective study, infants with an early seizure onset continued to perform worse at 24 months of age, in comparison with children with a later seizure onset. 36. Data from the TSC Natural History Database, including 1965 subjects with TSC, showed that early focal onset seizures and treatment-resistant infantile spasms were clinical predictors for DRE. 57. Infantile spasms were also among strong indicators of DRE, as reported in a systematic TSC review. 50. In a longitudinal observational study of 40 infants interictal epileptiform discharges, IEDs, correctly identified future epilepsy in 77% of seizure-naive infants. 45. However, due to the high prevalence of epilepsy in TSC patients, 80–90%, we cannot confirm the predictive value of IEDs. The EPISTOP study has recently identified useful pre-symptomatic genetic, EEG, and MRI biomarkers that can be used in clinical practice to identify infants at risk for developing DRE at the age of 2 years. 1860–63. TSC2 pathogenic variants were associated with a higher tuber load on MRI and were predictive of more severe epilepsies with higher risk of drug resistance. 64. Interictal focal or multifocal discharges on serial sleep-wake EEG in pre-symptomatic infants with TSC are predictive of an ongoing severe epilepsy. 21. 95% of infants with TSC enrolled in the EPISTOP trial developed IED at a median age of 77 days. An earlier recording of IED was associated with an increased risk of DRE, 62–65. Although fetal MRI brain lesions did not predict the risk of clinical seizures or DRE at the age of 2 years, 34, higher fetal lesion load was significantly associated with lower developmental outcome. Furthermore, higher tuber volume as a proportion of total brain volume on early postnatal MRI was associated with clinical seizures and DRE at the age of 2 years, 66. In a prospective observational cohort of 123 infants, tuber location was heterogeneous. However, tubers functionally connected to the globi pallidi and cerebellar vermis were stronger predictor of spasms. Main 7. Increased EEG connectivity was strongly associated with epileptic spasms in another cohort. 68. In summary, early recognition of pathogenic variants and the use of reliable EEG and MRI biomarkers could help to identify pathogenic mechanisms for epileptogenesis and provide opportunities for pre-symptomatic and disease-modifying approaches. Clinical, EEG, MRI, and genetic predictors of DRE are summarized in development of a prediction model that incorporates a variety of risk factors, as well as machine learning models with multimodality features could aid in guidance and treatment of TSC patients with high risk of DRE or neurodevelopmental disorders. And 69–72. Predictors of drug resistance, ES epileptic spasms, IEDs, interictal epileptiform discharges are right. 4. Pre-symptomatic treatment. Pre-symptomatic treatment with VGB was already suggested by the previous expert panel in 2018, but its efficacy is now strongly confirmed by the EPISTOP trial. 18. The EPISTOP trial was carried out from 2014 to 2018 in 9 European centers and 1 Australian site. The aim of the trial was to evaluate the safety and efficacy of conventional versus preventive treatment of epilepsy with vigabatrin at the dosage of at least 100 mg/day. Eligible patients were newborns and infants under the age of 4 months, before the onset of seizures. All participants were monitored with serial EEG, and vigabatrin was introduced either when IED were detected or after the onset of seizures. Preventive treatment with vigabatrin in 25 children resulted in delay of clinical seizures, reduced risk of developing drug-resistant epilepsy, and absence of infantile spasms, when compared with 25 patients taking treatment after seizure onset 18. In the EPISTOP study, treatment with vigabatrin in TSC infants was safe and modified the natural history of seizures, reducing the risk and severity of epilepsy. Since epilepsy was not prevented in the majority of infants, the term pre-symptomatic treatment is to be preferred and is now considered an established approach in several European countries in infants with TSC. C971. Supporting this more proactive use of vigabatrin for TSC epilepsy, new data published from the U.S. Vigabatrin Registry that followed 9,000 patients on vigabatrin for up to 16 years did not find that any patient experienced clinical vision loss. Few 2% patients experienced new vision findings over time, and none were determined to be caused by vigabatrin. Thus, the risk to vision appears lower than previously thought, Siditun. Furthermore, early and frequent EEG monitoring and early before any type of seizures, after electrographic seizure, or immediately after first clinical seizure, treatment resulted in better neurodevelopmental outcome than in any other historical cohort of TSC patients, median IQ within the normal range in the whole cohort. However, longer follow-up is warranted before firm conclusions can be drawn with respect to neurodevelopmental outcomes. 18. Autistic features were detected irrespectively of treatment strategy, suggesting either independent mechanisms or the impact of earlier epileptogenesis-related events since intrauterine life. 53. 5. Targeted treatment with mTOR inhibitors. mTOR inhibition can reduce structural abnormalities in the brain. mTOR inhibition reduces neuronal morphology abnormalities, cell size and inflammatory mediators in the cortex, and improves neuronal myelination and synaptic plasticity. Initially developed as antifungal agents and later discovered to have potent immunosuppressive and antiproliferative properties, rapamycin sirolimus has been found to be a mechanistic target of mTOR overactivation. Rapamycin is a macrolide compound, isolated for the first time in 1972 from samples of Streptomyces hygroscopicus found on Easter Island. A mechanistic target of rapamycin kinase, mTOR inhibitor, acts on T and B cells by reducing their sensitivity to interleukin-2, IL-2. The compound was approved by the FDA in 1999 as immunosuppressant indicated for the prophylaxis of organ rejection in patients aged 13 years receiving renal transplants and patients with lymphangioliomyomatosis. Rapamycin sirolimus changes microglial polarity in TCS mice, 1974. It has also been shown to decrease seizures and neuropsychiatric symptoms, except for ASD, and this effect seems to be related to the regulation of microglia polarity in TSC mouse models, 75-77. Recent uncontrolled studies demonstrated a favorable safety and efficacy profile of sirolimus for treating manifestations of TSC, including epilepsy. The study reported on efficacy and safety of rapamycin in DRE in 32 children aged 11 months to 14 years. At least 50% reduction of seizures was seen in 56% of patients, 70-hour. However, long-term efficacy safety data from prospective controlled studies in TSC are only available for everolimus. Everolimus, the 40O2-hydroxyethyl derivative of sirolimus, is a second-generation rapamycin derivative and works similarly to sirolimus as an inhibitor of mTOR pathway. Although having a similar structure, everolimus significantly differs regarding its pharmacokinetic, pharmacodynamic, and toxic properties, resulting in distinct clinical profile. Everolimus is more readily absorbed, exhibits a greater oral bioavailability, and is a selective inhibitor of mTORC1 with little impact on mTORC2. Therefore, it could achieve many of the benefits of sirolimus on cell growth and proliferation without glucose intolerance. There are still ongoing efforts to limit the non-neurologic effects of mTOR inhibitors. Indeed, experimental studies showed that brain-specific analogs of rapamycin, termed rapalogs, have recently been developed by inhibiting brain mTOR while sparing mTOR activity in other tissues using the brain-permeable mTOR inhibitor, rapalink-1, and the brain-impermeable FKBP12 ligand rapablock. AAT. Everolimus has been considered as an add-on treatment option for individuals with TSC-associated drug-resistant epilepsy. Treatment efficacy and safety were reported in the EXIST-3 trial, where adjunctive everolimus achieved a clinically meaningful reduction of seizure frequency with a favorable risk-benefit ratio, 19 and an 81. Furthermore, response to everolimus tends to improve with ongoing treatment, and the post-authorization safety study PASS confirmed the long-term safety of everolimus in the real-world clinical practice, and a better response for the 6-year subgroup was documented, 82,083. The target drug concentration of 5 to 9 ml was recommended, 81. Everolimus has been also studied as the treatment of TSC-associated neuropsychiatric disorders in a RCT study in patients aged 6 to 21 years, comparing oral everolimus, NHR32, versus placebo, NHR15, taken once daily for 6 months. Comprehensive neurocognitive and behavioral evaluation battery was administered at baseline, 3 months and 6 months. At the end of the study, everolimus did not significantly improve neurodevelopment or behavior in children with TSC, possibly related to small sample size, study design and outcomes chosen. 84. However, the panel believed that definitive conclusion could not be provided for the efficacy of everolimus on cognition, considered that the drug was used in individuals with older than 2 years of age, with already significant neurodevelopmental deficits. Recent evidence showed that everolimus is safe also in young children under the age of 2 years. Since functional connectivity is important for neurodevelopment, the longitudinal effects of everolimus were studied on callosal white matter diffusion, tensor imaging, DTI, in patients with TSC. mTOR overactivity on white matter microstructural integrity in TSC were modified through pharmacologic inhibition of mTOR. 86. However, how this affected neurodevelopment was not studied. Everolimus was used in a preclinical model of TSC induced by TC2 plus OS, and it led to a persistent improvement of the social deficit, while deficits related to developmental status epilepticus did not respond to treatment. None. What is still not known is the optimal timing for mTOR inhibition and its applicability in fetal life. If everolimus was used in a pregnant woman to treat her fetus with TSC and regression and subsequent stabilization of the cardiac and brain lesions were seen. Postnatally, the child did not develop seizures or autism and presented good neurodevelopmental outcome, 9. Since mTOR inhibitors may have effects on various systemic manifestation of TSC, the panel suggests that everolimus should be considered early when growing subependymal giant cell astrocytoma, SIGA, or angiomyolipoma, AML, are seen in combination with DRE 90. Supporting evidence for the efficacy of combination treatment with sirolimus and everolimus in treating the same different TSC manifestations should be available, as there are currently no head-to-head published studies. It is important to demonstrate if dual targeting of TOR2 provides superior efficacy above sirolimus or everolimus as monotherapy without significant increases in toxicity. In addition, and in contrast to oncology, sirolimus in TSC patients is used in monotherapy in young patients and therefore might have fewer side effects. 6. Surgery, relevance, and limitations. In 2017's workshop, the panel was already suggesting that surgery can be a good therapeutic option for TSC in a well-selected population of patients with recommendation of early pre-surgical evaluation to attempt to improve neurodevelopmental outcome as well. New evidence emphasizes and strengthens this recommendation. Overall postoperative seizure freedom is achieved in 50 to 60% of TSC patients, and 50% seizure reduction is seen in another 15%, even in patients with multiple tubers. In selected series, it has been observed that duration of follow-up matters, as there is a substantial decrease of seizure-free patients with a longer follow-up. 91. Epilepsy surgery in TSC is still underused. 92. Indication have long been limited to clear unifocal epilepsy, but the great majority of patients have multifocal EEG abnormalities and numerous tubers. Thus, indication may need to be widened, taking the high burden of predominant seizures into account, especially when semiology is consistent over time. A recent nationwide multi-center retrospective study in 364 patients who underwent surgery at the median age of 8.5 years reports sustained seizure freedom in 51% at 10 years, particularly after complete removal of a large lesion on MRI or after tuberectomy plus cortectomy, meaning the epileptogenic zone beyond tuber borders. 83. A systematic review of 46 studies regarding the outcome of 1157 patients showed an excellent seizure reduction in 59% of the individuals who underwent epilepsy surgery. 91. Very early onset epilepsy, the absence of a tuber which is expected to predominate in generating epileptiform abnormalities and seizures, and continuing spasms are probably related to worse outcome. Developmental progress, but very limited improvement in the standard scales, was reported in a subset of individuals who showed a worthwhile reduction of seizures frequency. T-form. Altogether, more information on causes of surgical failures and predictors of efficacy is needed in 2295-96. But importantly, patient satisfaction, even in patients who did not achieve seizure freedom, was high. 97. Laser ablation was performed in 3 patients with promising results, but more data is needed to recommend its use in TSC patients. 898. The current relevance and limitation of surgery for TSC-associated drug-resistant epilepsy was widely discussed by the panel. Pre-surgical evaluation should be considered in all TSC patient with DRE and consistent semiology, concordant with EEG and MRI findings. On the other hand, children with multiple seizure types, multiple cortical tubers, and multiple EEG abnormalities remain a challenge for pre-surgical evaluation, and likely post-surgical seizure freedom will not be achieved. The panel proposed that the identification of ideal candidates for surgery should be performed at expert centers specialized in both TSC management and epilepsy surgery, and emphasized that it should be tailored with ancillary investigations as high-resolution source imaging, single photon emission, computed tomography, SPECT, or invasive recording to the individual patient. 7 other treatment options. 2 recent studies confirm that both ketogenic diet therapies, KD, and vagal nerve stimulation, VNS, could be of benefit in reducing the seizure frequency in individuals with the refractory epilepsy who are not suitable for epilepsy surgery. 199-102. In a meta-analysis on the role of VNS in genetic epilepsies, VNS showed a significant effect on the proportion of patients with a 50% seizure reduction, CNR 5.75, P 0.001. Heterogeneity, I2 around 40.96%, PR 0.6, and publication bias, PRR 0.72, were non-significant. In the same meta-analysis, the pooled 95% CI seizure freedom rate was 40%, 12% 71%. 90% seizure reduction rate was 31%, 8% 56%, and 50% reduction rate was 68%, 48%, 91%, 100. In a cost analysis of competing therapeutic options for drug-resistant seizures associated with TSC, a probability of positive outcome, Engel class 1, was 0.55 for resective surgery, 0.12 for VNS, 0.0 for KD, and 0.20 for mTOR inhibition, respectively. 103. KD can be an effective therapeutic strategy for seizures, particularly in infancy and early childhood. 101, 102. In an international placebo-controlled randomized clinical trial to evaluate the efficacy and safety of cannabidiol, CBD, in 224 patients with TSC-associated seizures, CBD at dosages of 25 or 50 millimol a day significantly reduced seizure frequency if compared with placebo, with no significant difference in efficacy between 25 and 50 millimolar a day. The most common adverse events were diarrhea, somnolence, and elevated transaminase, more often seen at higher dosages, 20. A good safety and efficacy profile was reported in 199 patients who entered the open-label study to evaluate long-term safety and efficacy with add-on CBD, 104. Importantly, CBD is known to significantly increase serum levels of mTOR inhibitors, and such combined therapy requires dosing modification and close monitoring. In patients taking both CBD and everolimus, the everolimus dosage should be reduced by nearly a half, and through levels should be monitored regularly. 105-106. CBD is hypothesized to act at a synaptic level by reduction in excitatory neurotransmission through at least three possible mechanisms: block of GPR55 receptors, desensitization of TRPV1 channels, or inhibition of ENT1 adenosine reuptake pumps, E107,108. Interestingly, CBD is also shown to be a selective modulator of the mTOR downstream molecule RPS6 in the brain in a preclinical model of TSC 109. Ganaxolone, a positive allosteric modulator of GABA, a receptor, was approved within the USA for the treatment of seizures associated with CDKL5 deficiency disorder, CDD, in March 2022, 1 and 10. Its use is under evaluation in a phase 3 study, TRUST TSC, and could play a role as an emerging treatment for TSC-associated seizures. In a recent RCT, metformin reduced seizure frequency compared to placebo in 21 patients. Ideally, these results would need further confirmation with adequate statistical power. The relatively small number of patients included in this RCT hamper firm conclusions, and at present this panel cannot recommend the use of metformin. 8 conclusions. Epileptogenesis in TSC is a chronic and dynamic process. Different convergent and divergent mechanisms are involved in the establishment of a pathological network capable of generating seizures and co-occurring neurodevelopmental disorders. mTORC1 dependent and independent mechanisms may occur in parallel and interact throughout. Therefore, combinatorial treatment strategies to engage different targets involved in the epileptogenic network have been hypothesized and referred to as network therapy, or HIN. In TSC, this is still a hypothesis, and a careful selection of patients for any combination treatment is important. More data on its modifying effect is needed before combination therapy can be recommended in daily clinical care. In addition, there are important observations of spontaneous remission of epilepsy with age that need to be acknowledged. 1 and 3. To identify the contribution of mTOR dependent and independent mechanisms to the clinical phenotype, and to explain failures with targeted treatment with mTOR inhibitors, exploring combination treatment strategies may be of interest. There is recent experimental evidence showing that ASD phenotypes in TSC may result from a combination of TSC1, TSC2 molecular deficits, and additional social impairments caused by seizures, but through different mechanisms that may not all respond to mTOR inhibitors. 85. Compared to the recommendations compiled 5 years ago, the panel believes that substantial progress has been made thanks to the early identification of risk factors, which can predict both the impending epilepsy and the possibility of a severe drug-resistant epilepsy. Furthermore, pre-symptomatic assessment and treatment with vigabatrin are now more and more adopted in very high-risk infants. The panel concluded that the clinical approach for TSC-related epilepsy has vastly improved over the last few years, based on the progress in predicting and modifying strategies and on the advent of molecular-targeted therapy. Progress in the knowledge of the mechanism underlying epileptogenesis has paved the way for new concepts in the management for TSC-related epilepsy. Developmental neurobiology and neuropathology offer a practical basis for approaching such concepts, and early genetic diagnosis and use of reliable EEG and MRI biomarkers may allow the development of pre-symptomatic and disease-modifying strategies. The panel acknowledged the need to develop and validate a scoring method to calculate the relative risk of impending epilepsy and timing of preventive treatment. The goal is to develop a more robust and accurate prediction model that importantly guides counseling and treatment. Based on the results of the EPISTOP trial, the panel emphasized the importance of a close developmental follow-up of infants with TSC at a sensitive developmental time points, 6, 9, 12 months, for an early detection of possible delay in motor, language, or cognitive developmental trajectories. Early intervention strategies are crucial to improve the neurodevelopmental outcome. All infants with a definite diagnosis of TSC should be followed up with early and frequent EEG monitoring every 4 weeks in first 6 to 8 months, and every 4 to 8 weeks thereafter until 12 months, and every 12 weeks between 12 and 24 months, to detect the appearance of interictal epileptiform discharges and abnormal background patterns. Pre-symptomatic treatment with vigabatrin as soon as focal spikes occur, but when multifocal spikes, pre-hypsarrhythmia, hypsarrhythmia, Subclinical seizures are recorded on EEG, delay seizures, and DRE risk, and should be used in all patients. The panel emphasized the need to identify the subpopulation of infants that have an even higher risk to develop epilepsy and ASD. Moreover, parents should be trained to recognize the appearance of subtle focal seizures or atypical behavior or development early. All infants with a definite diagnosis of TSC should be evaluated with standard developmental scales at 6, 12, 18, and 24 months to detect early deviations in motor, language, and cognitive trajectories. Initial neurodevelopmental atypias in children with TSC may represent a risk of later ASD diagnosis. For references and full article link, see video details below. Thanks for listening, and we hope it is helpful to you. Dr. Hamza Alsayouf, Child Neurologist, American Board, Amman, Jordan.